Before we begin, take a moment to slow down. Relax your shoulders. Unclench your jaw. Let your breathing become natural. There is nothing you need to do right now. Nowhere you need to rush. Just listen. This is a story about the future, about intelligence, and about a question humanity is only beginning to understand. So sit back, focus, and let's begin. Healing and deadly power of belief. Placebo and Nocebo. How does the mind trick the body? Part 1 of the sweet lie that changes flesh. There are some miracles people trust because they can see them. A wound closes. A fever breaks. A hand stops shaking. Pain loosens its grip. A patient who looked exhausted yesterday sits up today and says, almost in disbelief, "I feel better." Medicine likes to imagine that these moments always belong to chemistry. A molecule enters the body. A receptor responds. A pathway changes. The symptom retreats. But that is not the whole story. Sometimes healing begins before the drug has even had time to work. Sometimes it begins when the white coat enters the room. When the voice sounds confident. When the label on the bottle looks serious. When the ritual of treatment tells the nervous system, help is here now. That is where the placebo effect begins. Not in fraud. Not in magic. But in expectation. The U.S. National Center for Complementary and Integrative Health defines the placebo effect as a beneficial health outcome resulting from a person's anticipation that an intervention will help. It also notes that the way a healthcare provider interacts with a patient can itself produce a positive response independent of any specific treatment. Modern placebo science goes even further. Placebo effects are now understood as real psychobiological events, not mere imagination, and they have been documented across pain, Parkinson's disease, depression, anxiety, sleep, cardiovascular functions, and immune-related responses. That is why the placebo effect is so disturbing, because it forces us to admit that the border between a real treatment and the meaning of treatment is not clean. The body does not wait passively for molecules alone. It listens to context. It reads signals. It predicts outcomes. And those predictions can become physiological events. Imagine a patient in pain. The tablet is small, harmless, chemically inert. But it arrives inside a ritual older than modern medicine itself. Diagnosis, prescription, trust, authority, care, hope. The patient swallows not just a pill, but a story. And in some cases, the brain answers that story with real measurable changes. Pain research has shown this most clearly. Placebo analgesia has been linked to activation of the brain's own pain-suppressing systems, including endogenous opioid pathways. PET imaging studies found that placebo treatment with the expectation of relief activated micro-opioid neurotransmission in regions such as the anterior cingulate, orbitofrontal cortex, insula, amygdala, nucleus accumbens, and periaqueductal gray. Earlier work had already shown that placebo analgesia could be reversed by naloxone, meaning the body was not merely pretending to feel less pain, it was recruiting some of the same opioid-linked machinery involved in genuine pain relief. And then the picture became even stranger, because placebo does not only touch pain. In Parkinson's disease, expectation itself has been linked to dopamine release. Reviews and imaging studies have shown that when patients believed they might be receiving an effective treatment, the brain could release endogenous dopamine in the striatum, and those placebo responses could correlate with changes in symptoms. A major JAMA psychiatry study found that placebo and nocebo effects were associated with the opposite dopamine and opioid responses, especially in reward-related circuitry such as the nucleus accumbens. In other words, belief was not floating vaguely above biology. It was entering the reward and motor systems directly. This is the point where people usually become uncomfortable, because as long as placebo means it was all in your head, the world stays simple. But once placebo means your expectations can alter pain circuitry, neurotransmission, motivation, and symptom experience, the old hierarchy collapses. Mind is no longer the opposite of body. Mind becomes one of the body's ways of acting on itself. And science now knows at least some of the routes by which that happens. Expectation is one route. Learning is another. The modern literature consistently points to two major behavioral mechanisms behind placebo and nocebo effects: expectations and learning. Expectations can be shaped by what a clinician says, by what a patient has experienced before, and by how treatment is framed. Learning can arise through classical conditioning, for example, when a body repeatedly experiences relief after a certain ritual and later begins to respond to the ritual itself. Observational learning matters too. Seeing other people improve can increase one's own placebo response, while seeing others suffer can strengthen nocebo effects. That means placebo is not just about sugar pills. It is about the whole theatre of treatment. The colour of the pill, the price of the intervention, the confidence of the doctor, the prestige of the clinic, the memory of previous cures, the reputation of the brand, the expression on the nurse's face. Modern reviews describe placebo effects as arising from the rituals, symbols, and psychosocial context of treatment, not only from inert substances. In fact, placebo-related effects can appear even without giving a classic placebo at all. Words, attitudes, and context alone can sometimes shift symptoms. Research reviews also note that expensive-seeming treatments, branded treatments, and stronger expectations can amplify placebo effects and in some cases perceived side effects as well. This is why placebo can survive even when deception is removed. For a long time, people assumed placebo only worked if the patient was tricked, but that assumption is no longer secure. One of the most influential clinical trials in this area tested open-label placebo at irritable bowel syndrome, meaning patients were explicitly told they were receiving placebo pills, not hidden medication. Even then, the study concluded that placebos administered without deception may be effective in IBS. A later systematic review and meta-analysis of open-label placebo trials found a significant overall effect across conditions such as back pain, cancer-related fatigue, ADHD, allergic rhinitis, major depression, IBS, and menopausal hot flushes, while also emphasizing that the field is still young and methodologically challenging. That is extraordinary, because it suggests the mind does not need to be fully fooled. Sometimes it is enough for the patient to understand, at least in broad terms, that placebo responses are real, that the body can respond to treatment rituals, and that expectation itself may help mobilize relief. The placebo effect, then, is not merely gullibility. It is a feature of embodied prediction. The brain is constantly guessing what comes next. If relief is expected, some systems begin preparing for relief. If safety is expected, some alarms begin to quiet. If help is expected, some symptoms may soften. And sometimes those changes are powerful enough to embarrass medicine itself. Few examples are more dramatic than sham surgery. In a landmark trial on arthroscopic surgery for osteoarthritis of the knee, patients were randomly assigned either to real arthroscopic procedures or to placebo surgery. The placebo group underwent skin incisions and a simulated procedure, but not the therapeutic surgical step itself. The result was deeply unsettling. Outcomes after arthroscopic lavage or debridement were no better than outcomes after the placebo procedure. The ritual of surgery, anesthesia, incisions, clinical theatre, expectation, recovery have produced benefits strong enough to rival the actual operation in that setting. This is not proof that all medicine is theatre. It is proof that theatre is part of medicine whether medicine likes it or not. That is the first great psychological truth hidden inside placebo. Humans do not heal in a meaning-free environment. The body reads signals of threat and safety constantly. A treatment never arrives naked. It arrives wrapped in implication. And if the implication is powerful enough, the nervous system may begin to change the symptom before the pharmacology fully has its say. But placebo is not a blank check miracle. It is strongest and best studied in areas like pain, symptoms, expectation-sensitive conditions, and some neurologic and behavioral domains. Large reviews emphasize that placebo effects vary widely by condition, context, and mechanism. There is no single placebo effect, but many placebo effects across systems such as pain, gastrointestinal conditions, sleep, mood, cardiovascular function, and Parkinson's disease. The effect sizes can range from small to large depending on the domain and design. That nuance is important, because placebo is often either exaggerated into mysticism or dismissed into insult. Neither is accurate. It is not proof that mind can simply command reality at will, and it is not proof that symptoms relieved by expectation were fate to begin with. Placebo does not reveal that suffering is imaginary. It reveals that suffering is modifiable. That is a very different claim. A patient whose pain eases because the brain engages endogenous opioid and reward circuitry is not inventing pain. The pain was real. The relief is real too. What changes is the route by which the body gets there. And that is what makes placebo so narratively powerful, because it suggests that the body is not a passive machine waiting for repair. It is a prediction engine, a learning system, a social organ, a biochemical audience reacting to the drama of care. The pill matters, but the room matters too. The molecule matters, but so does the expectation surrounding it. So part 1 ends with a dangerous realization. Sometimes belief does not merely colour healing. Sometimes it helps produce it. A harmless tablet quiets pain. A ritual triggers endogenous opioids. A Parkinson's patient's expectation is linked to dopamine release. A fake surgery rivals a real one. An honestly labelled placebo still helps some patients feel better. And somewhere inside all of this is the first great shock of placebo science. The body is not only healed by what enters it, it can also be changed by what it expects. Part 2, the dark twin, when fear becomes pharmacology of placebo, is the sweet lie. Nocebo is the dark prophecy. It is the moment medicine speaks harm into the room and the body begins listening. Because just as positive expectation can relieve symptoms, negative expectation can worsen them. Modern reviews define the nocebo effect as the harmful counterpart of placebo, adverse outcomes caused or amplified by expectation, context, prior experience, observation, and the social meaning of treatment. In clinical trials, people taking inert placebos can still report side effects that mirror those reported by patients taking active medication. That is not because their suffering is invented. It is because anticipation of harm can itself become biologically active. This is where the subject becomes truly frightening. A patient reads the side effect leaflet. A doctor warns that NOS is common. Someone online describes the drug as terrible. A friend says the injection felt awful. The body waits. And then the symptom arrives. Nocebo research shows that these effects can be generated by verbal suggestion, previous bad experiences, observational learning, negatively perceived clinical communication, and even mass psychogenic modeling. In the 2023/2024 review by Luana Coloco, nocebo effects are described as neurobiological phenomena associated with actual or perceived harm. The review also notes that nocebo effects can decrease treatment compliance, increase unnecessary medical visits, and lead patients to take additional medication just to counter symptoms that expectation itself helped create. So the mind does not merely worry, it primes. It heightens vigilance. It scans the body for evidence. It amplifies ambiguous sensations. It recruits stress pathways. It converts possibility into felt experience. And once that process begins, fear can become self-confirming. A slight stomach sensation becomes nausea. A mild ache becomes evidence that the drug is harming you. A harmless flutter becomes a sign something is wrong. The body is no longer just experiencing symptoms. It is searching for them. This is one reason nocebo can be more corrosive than many people realize. It does not simply make people uncomfortable. It can undermine treatment itself. Reviews note that nocebo effects can cause non-compliance, discontinuation, worsening symptoms, and unnecessary healthcare use. In other words, nocebo does not merely alter perception in a trivial way. It can change clinical outcomes by pushing people away from therapies that might otherwise have helped them. And just like placebo, nocebo is not only psychological. It has biology. The St. Thomas psychiatry study that linked placebo effects to dopamine and endogenous opioid activation found that nocebo responses were associated with the deactivation of those systems. Other work has connected nocebo hyperalgesia to cholecystokinin-related mechanisms and stress-linked neurobiology. Translational Psychiatrist 2022 review summarizes that placebo and nocebo may evolve overlapping but opposite responses in pain modulation and reward circuitry, while some studies suggest distinct networks in substances, including cholecystokinin and nocebo effects. That means fear is not floating above the body. It is entering it. The nervous system, hearing the possibility of harm, begins to prepare for harm, and preparation itself can become suffering. This is why the title's phrase of the healing and deadly power of belief and fear is not entirely metaphorical. Nocebo does not usually kill in the cinematic sense of dropping patients dead through pure suggestion alone, but it can worsen pain, modify side effects, sabotage adherence, and deepen vulnerability in ways that become medically serious. In chronic illness, in pain treatment, in medication adherence, in procedural anxiety, nocebo can be destructive enough to matter at the level of outcome, not just mood. And the clinic itself can become the delivery system. This is perhaps the cruelest insight in all nocebo research. A doctor can accidentally harm by telling the truth badly. The ethical problem has been discussed for years. Articles on informed consent and nocebo warn that the very act of describing possible side effects may sometimes induce those side effects, or at least increase their likelihood and intensity. That does not mean patients should be deceived or denied informed consent. It means communication has physiological consequences, and medicine cannot pretend language is inert. Think about how terrifying that is for modern medicine. A doctor must warn you honestly, but the warning itself may change what your body does next. If the message is framed harshly, catastrophically, impersonally, or without context, it may seed a nocebo response. If the message is framed carefully, honestly, and with reassurance, the same facts may land differently in the nervous system. The 2022 Translational Psychiatry Review explicitly discusses the importance of psychosocial approaches, including expectation shaping, learning, and social interaction, for harnessing placebo effects and minimizing nocebo effects in clinical care. This is why the old fantasy that medicine is pure chemistry is so inadequate. Meaning enters through the mouth of the clinician, through the posture of the body, through the cost of the treatment, through the waiting room, through the reputation of the hospital, through what other patients say, through what the patient already fears. Even price can matter. The same Translational Psychiatry Review notes that higher-priced placebo treatments can produce stronger pain relief, but the expensive treatments may also increase perceived side effects, because people infer that stronger medicine is both more effective and more dangerous. Expectation cuts in both directions. Hope can intensify relief, fear can intensify harm. And because nocebo feeds on anticipation, it is strengthened by repetition. If the patient has had a bad experience before, the body may learn it. If a family member suffered, that story may function like conditioning. If a community spreads fear around a drug or intervention, social observation can take over. Coloca's review explicitly includes prior learning-based experiences, social observation, and clinical encounters among the drivers of nocebo effects. This makes nocebo not just a private psychological event but a social one. Fear can become contagious. That is why the nocebo effect belongs not only to hospitals but to culture. A medication becomes infamous online. Patients arrive already braced for suffering. Forums become expectation factories. The body enters treatment half convinced it is under attack. Then the first mild symptom arrives and is interpreted through that fear. In that sense, nocebo is not just the evil twin of placebo. It is the body's conversion of warning into physiology. And still, there is one twist that makes the whole picture even stranger. Sometimes even knowing about placebo or nocebo changes the effect. Open-label placebo studies show that beneficial placebo responses can still occur without deception. More recent work also explores whether educating patients about nocebo might reduce harmful expectations. The science here is still developing, but the general direction is clear. Awareness does not necessarily destroy these effects. The mind-body system is not fooled only by ignorance. Sometimes it responds to framing, ritual, and meaning even when the person consciously understands what is happening. That means the real lesson is not people are gullible. It is that human physiology is interpretive. The body is reading the world constantly. Treatment is one of the worlds it reads. And fear and hope are not just emotions riding alongside medicine. They are part of the medicine's context, and sometimes part of its effect. This also explains why placebo and nocebo are so important in clinical trials. Placebo effects can make ineffective treatments look better than they really are, while nocebo effects can make tolerable interventions look more harmful. That is why randomized, placebo-controlled trials became the gold standard for testing therapies in humans. Comparing an intervention to placebo helps separate the specific effect of the treatment from changes that come from expectation, context, chance, and symptom fluctuation. NCISA states this directly in its overview of placebo-controlled trials. But even there, the story does not become simple. Because clinical trials do not merely remove placebo and nocebo, They reveal how powerful those forces already were. The active drug must beat the story around the drug. It must beat the ritual, the hope, the vigilance, the fear, the natural variation, the regression to the mean, and the emotional weight of being treated at all. That is a difficult contest. And perhaps that is why the placebo/nocebo story is so unsettling. It reveals that medicine never acts on a silent body. It acts on a body already narrating what is happening to it. If the narrative is safety, relief, competence, and trust, the body may move toward healing. If the narrative is danger, doubt, catastrophe, and suspicion, the body may move toward symptom and harm. Nocebo is not witchcraft. It is not weakness. It is the cost of having a nervous system built to forecast danger and prepare for it. And placebo is not magic either. It is the reward side of the same architecture. The brain predicts. The body follows. Sometimes for the better. Sometimes for the worse. So who is tricking whom? The mind does not exactly trick the body as if they were separate enemies. They are one loop. Belief shapes expectation. Expectation shapes neurochemistry. Neurochemistry shapes symptom experience. Symptom experience confirms belief. That loop can heal. And it can wound. So part 2 ends with a darker scene than part 1. A patient sits in a chair, listening. Drug has not yet entered the bloodstream in meaningful amounts, but the sentence has already entered the nervous system. A side effect is named. A danger is imagined. The body begins preparing to feel it. And because preparation is biological, the fear stops being abstract. It becomes pulse, stomach, pain, sweat, tension, vigilance. That is the real terror of nocebo. You do not need poison for the body to move toward harm. Sometimes expectation is enough to start the descent. And that is the final truth behind both placebo and nocebo. The mind is not outside the body, whispering illusions into it. It is one of the body's control rooms, which means that hope can become analgesia. Fear can become suffering. A ritual can become relief. A warning can become symptom. And the line between chemistry and meaning is far thinner than medicine once wanted to believe.